So we shall be discussing a few OSCEs today. All right. So this is where I don't have much to teach you. This is where you guys have to answer, and we'll discuss, what are the correct methods to describe. And, there are going to be 15 OSCEs and 15 topics, we will revise through that. Okay. All right. So let's go with the first one. So typically, the questions that they'll give you would include clinical cases with findings, and most of the times 2 questions out of all questions would be uh, 2 questions would be about the findings being described and the diagnosis. Okay, so anybody wants to describe this? How are you going to describe this lesion? So always remember, whenever you are describing, one is the mass characteristics and second is the extent. Always start describing one by one. Don't mix the two, right? So first thing that you want to do is localize, and so the very first thing in OSCEs that's not needed, but when you are presenting, that's needed, is describe the investigation. So here you have to first by saying that I have been given an axial CCT. In an OSCE you need not write all that it's an axial CCT. You may or may not write, it's fine. I mean, that doesn't really add to your marks. So now you have described it's an axial CCT at the level of the renal upper pole, and you want to then describe the mass lesion. So here we are seeing, what do you want to say first thing? It's a heterogeneous mass, right? So directly don't jump to the diagnosis. Ignore the diagnosis. That's the second question. They're not even asking it. So this is not a spotter. This is where you have to describe. So this is a heterogeneous mass with irregular margins. And what do you want to say? Anything else about the characteristics? So we can see central areas of necrosis. We can see few foci of calcification within. What else do you want to say? So let's start writing. So there is, while you write, your brain can think. So that way you will save time. So heterogeneous, ill-defined mass. We can't measure the size here, but a large mass, ill-defined, large mass with central areas of necrosis and few foci of calcification. Then we go on to extent. So we have described everything about the characteristics. Now we go on to the extent. Very, very important. What is the relationship with the kidney? What do you want to write here? Very important sign that you want to say. What do you want to say about the beak sign? We want to characteristically say that there is a negative beak sign. Yes, that it is not arising. It is causing mass effect of the kidney. So we want to say negative beak sign because that's the whole point of this lesion, right? That is it from kidney? Is it not from the kidney? So negative beak sign with kidney. What else do you want to say? Is the adrenal seen separately? So we have to say right adrenal not seen separately. Okay, here you do want to add right kidney. So right adrenal not seen separately, and that is our ghost organ sign. No need to write that. So we can say ghost organ. Embedded organ is not seen with an organ like adrenal, right? So we can't say embedded organ. That's the ghost organ or the invisible organ. You're not seeing the adrenal. And a very, very important extent that I need to describe is now with the IVC. What do you want to tell about the IVC? Is it invaded? Is it encased? Is it uninvolved? What do you think? What do you want to say for IVC? Is it anteriorly displaced? See again. It is invaded, right? You can see how this is the lumen and you can see the hypodense mass going into it. So we have to say there is IVC invasion, right? So you may write this in bullet points. Bullet point is always easier to check, but you can write it in prose form as well. Not a problem. Any other finding that you want to say? Fat planes with liver, we are not able to see in this lesion, but let's not comment. If we look at other planes, we will be able to better say. So we don't want to comment on this if we have nothing, confirmatory. So if we have nothing confirmatory to say, let's just leave it. We'll have to look at other planes. So on this image, this is the only thing that I can say. So what do you think? What is the likely diagnosis? So here, before you jump to adrenocortical carcinoma, we have to say that it is likely malignant lesion. Yes, likely malignant mass. First possibility is adrenocortical carcinoma. Yes, so that is how we are going to be going about this. Why can't it be exophytic lesion from liver? Look at the margins with the liver, right? So if it was from liver, you will see a beak sign with liver, something like this. You're not seeing any beak sign with liver, right? So it's very unlikely to be exophytic lesion from liver and then invading onto the IVC, right? So that is why, again, beak sign helps you. So if there was a beak with the liver, which tells you like a beak, a claw, that it is coming from liver. So that's why it's unlikely. Okay. Right. Again, this is infiltrating. This is no beak sign. This is infiltrating. In fact, you can use embedded organ here. So this is what is negative. Here, what you are seeing is not a beak sign. Yes. Phantom organ is when you don't see the organ of origin, typically described in adrenal, right? Beak is when you have a mass which is arising. For example, usually seen with renal masses, okay? Where you will see that there is a beak. So let's say this is the kidney and you see a mass like this. So when you see this beak coming, that is when you know that it is arising from a kidney. So when you have a cross section and you have a mass with a beak, that's how it is going to appear, okay? So that usually tells you about the organ, but other planes we will see and we'll better know. But with IVC invasion, think of adrenal masses first, okay? And in OSCE, sometimes, even if you are unsure, always look at the other question and then you will know that what is it coming towards. So rather than making a blunder and saying liver masses, see what the questions they are asking, and that way you will not go wrong, okay? You can't go wrong because other questions will be clues that adrenal socho. So that's the first thing that you do in OSCEs are just read all of the questions, okay? First, तो आपको idea लग जाएगा. Then you have a question between benign and malignant adrenal mass. So this is where you are supposed to draw a table. So just to help you out, I have already made this table. So this is what you can use, okay? So you will draw this table, benign versus malignant masses. This is there in our adrenal mass class as well, right? So size. Very good. 4 centimeter is the cutoff, less than 4 centimeter, well-defined mass, smooth margin, homogeneous. And now mentally I'm also checking, have I described everything? So we have described irregular margins. We have described that it's heterogeneous. Density we can't measure. So less than 10 HU is benign. MR imaging, ISO intense is benign. That's fine. Necrosis is rare in benign, common in malignant. And growth is rapid. So very, very basic things which you will anyways tell, right? So just basic things जो दिमाग में आती नहीं है usually, but you just have to remember this. Very important fourth question. Can you tell me the answers? Can you tell me 3 things which will point to a diagnosis of adrenal adenoma? Very good. First thing on NCCT, HU, how much HU is adrenal adenoma? HU of less than 10. So this is what we call as lipid rich adenoma. So this is lipid rich. Then what do you want to say? Can I use one MRI technique to again talk about lipid rich? Yeah. So if the NCCT HU is more than 10, that is a lipid poor adenoma. So then I can do chemical shift imaging. So chemical shift imaging पे क्या मिलेगा मुझे? Yes, it is suppressed on in an opposed phase, right? Which phase will it be suppressed? In phase or opposed phase? So we will see suppressed or loss of signal in which phase? Loss of signal in the opposed phase, right? So that is what we see as microscopic fat. So in chemical shift imaging, we are going to see the presence of microscopic fat indicating a lipid poor adenoma because HU is more than 10. So suppressed or loss of signal in the opposed phase. And the third feature is when we have the next question is leading up to it. So relative washout, absolute washout. Very good. So absolute washout is going to be more, relative washout more than 40%. Again, lipid poor adenoma. So tell me the formula. When we talk about relative, we are going to take into account the delayed image as well. At what time do we take the delayed image? So in absolute, we are going to take delayed, right? So venous minus delayed upon venous minus NCCT into 100. Yeah, delayed is taken. So this is what you want to mention, right? That delayed is at 15 minutes, venous phase is at 16 seconds, and NCCT is non-contrast. Okay, so this is what we do. Whereas in relative, we take venous minus delayed upon venous into 100. Okay, so this is what you want to mention. Right, so this is how you will get full marks or most of the marks depending on mood of examiner in this OSCE. Okay, so this is all about adrenal masses. Moving on to next one. This one is easy. So describe the imaging findings. So here we have to describe image wise, right? So the first image, first of all, can you tell me what is this image sequence?